So as we have decided that we will do a revision of maternal and child health, and we will do that revision through discussion of problem cards. Okay. So when you sit for the exam this year, there will be two Viva tables, right? In one of the Viva tables, you will be having the instrument tray and your family. You will come with your family notebooks and the instrument tray will be there, and that table will be family and Viva. Okay. The other Viva table will have some problem cards. Okay. Each problem card holds around 10 marks, right? So part of your questioning in that Viva table will be from the problem card that you are given. Okay. And rest of the questioning will be from the topics that will be covered in that Viva table, right? So like this you will have problem cards. So the problem cards we have divided according to topics, and as we do these subject wise revisions over this last 1 month, we will make it a point to discuss the problem cards that we will keep there, right? So the problem cards in your exam might not be exactly same, but they will be more or less like this only. Okay, maybe names will be changed, scenarios will be changed little bit. Okay. So we are going to try and do a revision of maternal and child health through 4 problem cards today. Okay, we'll spend roughly 15 to 20 minutes in each of the problem cards and we'll finish them, right? So going ahead, let us begin with the first problem card. So what we see, what is the story here? Sujata, a 32-year-old third gravida, came to the primary health center for antenatal checkup. At present, she has no living issue. On examination, there is no abnormality. History revealed that she had a spontaneous abortion during her first pregnancy, while the outcome of the second pregnancy was a stillbirth. So even though she has no living issue, this is her third parity. This is her third gravida, isn't it? And she has had 2 pregnancies before. One ended in a abortion, the other ended in a stillbirth, right? So the questions are, what is the schedule of an ANC visit? What is antenatal registration? What do we mean by registration of a pregnancy? What are the routine investigations to be performed during pregnancy, and who are at risk mothers, or what are at risk or high risk pregnancies? Okay, these are very, very common questions that even see these scenario based questions can come in your theory exam also. Now no longer you are just given a direct question like what are the provisions of this program, what are the strategies, what are the services, not like that. You may be given a scenario like this and given questions like this from which you have to answer based on your knowledge, applying your knowledge to this particular situation. So if you look at this problem card, what are the important points that we need to note in this problem card? What are the important things? So see, Sujata, first of all, Sujata is a third gravida, isn't it? She is a third gravida. She has no living issue. There is a history of spontaneous abortion during the first pregnancy, and there is history of stillbirth in the second pregnancy. So this is what the obstetric history that we have got. Going ahead with this, what is the schedule of ANC visit? So how many visits are mandated in our national program? A minimum of 4 visits, isn't it? A minimum of 4 visits. So as we know, under the RMNCHA, so what is the full form of RMNCHA? Now it is RMNCHA plus N. Reproductive, maternal, newborn, child and adolescent health plus nutrition. Okay. Now it is RMNCHA plus N. Okay. Because nutrition is a domain which covers everything. We know there is something known as intergenerational burden of malnutrition. What is intergenerational burden of malnutrition? Suppose there is a pregnant mother who is having malnutrition. What will happen? The pregnant mother will not be able to nourish the baby while the baby is in her womb. So as a result, there will be a low birth weight child, isn't it? A malnourished mother leads to the birth of a low birth weight child. Now that low birth weight child, because the child is low birth weight, it will have vulnerability to suffer from various infections. isn't it? It will suffer. So that low birth weight newborn will grow up into a undernourished or a stunted or a underweight under 5 child, isn't it? That same child, now under 5 period is the period of brain development and development of neuronal connections, isn't it? So if the child is not having proper growth during that period, when the child goes to school, so between 6 years and 10 years, when the child is a school going child, it is going to the primary school, at that time that child will not have good academic performance, isn't it? The child will not have good academic performance, and eventually as the child goes into adolescence, as the child goes into secondary school, the child will further falter. It will further falter in terms of growth failure. The child has an opportunity to catch up on the growth that was missed in the childhood during adolescence. But if the child is having severe problems with respect to malnutrition, then the child will even not be able to cope with adolescence. So during adolescence also what will happen? The child will not be able to perform properly academically. The child will not be able to contribute meaningfully in peer groups and to the family, and eventually, more common if it's a girl child, what will happen? If the academic performance is poor, she is not having proper growth, she is not contributing, what will happen? The family will think that marry her off. So, pregnant woman, malnourished, low birth weight child, undernourished, sick, under 5 child, grows up to be a sick adolescent who is eventually married off early. So, early marriage, what is the immediate consequence of early marriage? A teenage pregnancy. A teenage pregnancy. So, again the malnourished mother has a child who eventually again becomes a malnourished mother. So, this is the intergenerational burden of malnourishment. So, that is why nutrition is a component which has to be addressed for all age groups, from reproductive age group to mothers, like to pregnant women, to lactating mothers, to newborns, under 5 children, school going children and adolescents. That is why the program is now RMNCH A plus N. Okay, it is looking at all of the age groups of women and also looking at nutrition from a transgenerational point of view, where it is addressing every stage of life, right? So that is the program. Under that we have various programs, we will gradually discuss as we go ahead. So under RMNCHA framework, now the national government, it mandates at least 4 antenatal checkups, isn't it? And what is the timing of those checkups? The first checkup, which will be the checkup for registration of the pregnancy, should occur within the first trimester, which is within the first 12 weeks of the pregnancy. So every pregnancy must be registered and must have the first antenatal checkup within the first 12 weeks of the pregnancy, followed by the second visit, which is in the second trimester between 14 and 26 weeks, isn't it? Why? You will see that there is a gap of 2 weeks. The chains are not continuous. It is still 12, then it is 14 to 26, then it is 28 to 34. That is because if 2 visits are on consecutive days, one falling in second trimester, one falling in third trimester, even though it counts as 2 visits, it's essentially useless, isn't it? So to have the visits at least 2 weeks gap between successive visits, the mandate is like this, okay? The first visit within 12 weeks, second visit between 14 to 26, third visit between 28 to 32, and the last one between 36 weeks and term, okay? That is when they are going for safe confinement, isn't it? Either because we know that now we want 100% institutional deliveries. We do not want any delivery to be occurring at homes. So that is why between 36 weeks and term, they will go to the health center or the first referral unit or to the hospital, wherever it is planned, they will go and they will seek when they will get admitted for safe confinement, isn't it? So these are the minimum 4 antenatal checkups that should be done. What is the WHO mandate? According to WHO, according to World Health Organizations, what is the ideal number of antenatal visits? It is 8. Okay, it is 8 antenatal visits according to mandate of WHO. Indian government also says that 8 antenatal visits is ideal, but 4 is the minimum. At least 4 antenatal visits must be completed. So we do National Family Health Survey, you know, just few weeks back the National Family Health Survey 6 results have come out, NFHS 6 results have come out. In NFHS 6, when we look at completion of antenatal care, then we check whether at least 4 antenatal visits have been done or not. Okay. So essential mandatory antenatal visits is 4. Clear with everyone? Okay. So that's the first question. Moving on to the second question, what is antenatal registration? So antenatal registration is simply that if a pregnancy occurs, the pregnancy gets registered with the public healthcare system. That is, the moment a pregnancy, it is the formal process of enrolling a pregnant woman into the public healthcare system as early as possible, but strictly within the first 12 weeks of gestation. You need not take pictures, I will circulate the PPT, don't worry. Okay, ask your CR to contact me, I will circulate the PPT. Okay. So that does not mean that you will not concentrate now, that PPT will come, no need to listen, don't do that. Okay. So antenatal registration is just getting it registered within the as early as possible, preferably within the first 12 weeks. Now how to get it registered? Usually the process of registration is followed at the nearest subcenter. We know that the population is divided according to subcenters, and under a subcenter for every 1000 population there will be an ASHA, isn't it? Accredited social health activist. Okay. So an ASHA will be there for every 1000 population. So the ASHA who is responsible for that particular 1000 population, it is her responsibility that the pregnancy, the moment she gets to know about it, she takes the pregnant woman to the nearest subcenter and gets it registered within the first trimester. Okay. So that is the process of antenatal registration of pregnancy. Now if the pregnant woman does not come to the subcenter, but instead she goes to, maybe she comes directly to a tertiary care hospital, maybe she directly goes and comes to a subdivisional hospital, then the registration process will begin from there only and she will be mapped to her subcenter. Okay. So that is the process. So normally subcenter, but she can be registered at any place. It is not like it has to be the subcenter only. Okay. And the ASHA and the ANM have a important role in facilitating this process. Okay. So what is the significance? As we said, that first thing, the moment there is a registration, what we do, the mother gets a ID linked to the Aadhaar. The mother gets a ID, the mother and child tracking system. We have a mother and child tracking system. So the mother gets a ID and she is issued a mother and child protection card. Okay. All of you, please, after this class, if you have already not downloaded it, download the MCP card. The MCP card in English, the latest one, is available online. Okay. Download before you come for your exams, all of you. And just as a practicing doctor in India also, you should be knowing that what are the components, what are the headings that are there in the MCP card, what are the provisions that are there, what is monitored through that, at what intervals, who monitors what, right? That knowledge should be there with everyone. So if you do not have it, definitely download the MCP card, isn't it? So the moment a pregnancy gets registered, the mother is issued a MCP card. In that, and every following visit of the antenatal period and even after childbirth, immunization and everything is documented in that card. So that is very, very important. The moment the registration occurs, the MCP card is issued. Okay. Registration should occur within 12 weeks, but that does not mean that if the mother comes after 12 weeks, MCP card will not be issued. No, whenever she will come for the first visit, the pregnancy will be registered and a MCP card will be issued. But ideally, it should happen within the first 12 weeks, right? Next is, it allows for timely vaccination. So the mother is going to get 2 doses of tetanus and diphtheria, isn't it? TD. Previously it used to be TT. Now it is TD. So 2 doses of TD will be given at an interval of 4 weeks, right? So that will be given. Then the mother will also get iron folic acid supplementation for 180 days. 180 days of, that is 6 months of iron folic acid supplementation. Then deworming with albendazole after the first trimester. In the second trimester, there will be deworming with albendazole. Then calcium vitamin D tablets. Okay. So these provisions can be initiated. So IFA tablets will begin from beginning of second trimester. TD vaccination registration then again 4 weeks later. Then your albendazole second trimester. So if she does not get registered in the first trimester, the initiation of these things from the beginning of second trimester get delayed. That is why the registration should be in the first trimester, isn't it? And the third thing is we flag. Okay, the moment a pregnancy is registered, the pregnancy is classified as to whether it is a high risk pregnancy or whether it is a normal pregnancy. Okay, so there are some criteria based on which we decide whether a pregnancy is high risk pregnancy or not. If a pregnancy is flagged as a high risk pregnancy, then certain specific special care measures are undertaken, okay, under the national program. So that is why the moment a pregnancy is registered and at later stages also, usually there is a red stamp that is given on the first page of the MCP card that labels whether the pregnancy is a high risk pregnancy or not a high risk pregnancy, okay. Because if a pregnancy is high risk pregnancy, then its management will not be done at the PHC. Its delivery process will not be done at the PHC. It will be done at least at a FRU, a first referral unit. Okay, some PHCs can be upgraded to first referral units, there it can be done, but usually it will have to be done at least at a first referral unit. Okay, we'll come to it. What is a high risk pregnancy and all of that, we'll come to it. So, what is the schedule of ANC visit we have discussed, and what is the antenatal registration? We have also discussed this. Now, what are the routine investigations that are performed during pregnancy? So, this is a very common question for your MBBS exams. What are the investigations that are done in antenatal checkup? Or you are asked what constitutes antenatal care or comprehensive antenatal care, right? In that, the investigations that are done under the antenatal visits must be mentioned, okay. So, let us go forward and look at what are the investigations that are done. So, there will be some, first and foremost, there will be some blood tests. So, what are the blood tests that we do? We know that the most common problem of women or females, not just women, of males also, as we can see from the National Family Health Survey in India, is anemia, okay. So, the first and foremost investigation is hemoglobin level, where we screen for anemia, and based on this we will classify as moderate, severe or mild anemia, isn't it? We will come to that also. Next is blood grouping and RH typing, because we know RH incompatibility is a problem, okay. If the mother is RH negative and if the fetus is RH positive, then there can be some RH incompatibility problems, okay. So, blood grouping and RH typing, one is for this and second is if there is any requirement of transfusion during the process of delivery, okay, then also, so for that from early place RH typing and blood grouping will be done. Next, VDRL, VDRL is for, as we know, screening for syphilis, isn't it, screening for syphilis. Then HIV, so screening for HIV and syphilis, because these are both two infections which can be transmitted from mother to child. So, transplacental transmission of these infections occurs. So, we must know whether these infections are present in the mother or not. That is why a VDRL and a HIV screening is done routinely, isn't it? So, hemoglobin, blood grouping typing, VDRL, HIV. Next, hepatitis B also. So, syphilis, HIV and hepatitis B, all of these three infections are transmitted transplacentally. So, we will screen the mother for these three. Next, blood sugar. So, blood sugar testing is done usually with a oral glucose tolerance test. Usually, this is done in the second trimester, okay. A oral glucose tolerance test with 75 gram of glucose. This is not, a fasting blood sugar is not enough to rule out diabetes in pregnant women, okay. A OGTT is done in the second trimester, right. Next, malaria testing. Malaria testing is done only in places which are endemic for malaria. If you are considered in eastern India, it is endemic for malaria. So, we have to go for malaria testing as well, okay. Usually for malaria, rapid diagnostic tests are not done in these parts. What we do is a peripheral smear, okay. In northeast, maybe peripheral smear, if it is not possible, then they do rapid diagnostic tests. Here also at times, if rapid diagnostic kits are available, then rapid diagnostic testing might also be done. So blood investigations, what we will do hemoglobin, ABO and RH testing, then we will screen for syphilis, HIV, hepatitis B. Then we will do blood sugar by the oral glucose tolerance test and also screening for malaria, right. Next, urine tests. After blood tests come urine tests. So we screen for urine for albumin, urine for sugar and urine for routine microscopic examination, okay. Sugar again for diabetes, albumin for hypertension, okay, pre-eclampsia, eclampsia, okay. For hypertension in pregnancy, we do this urine for albumin, right. And finally, USG screening, okay, USG screening. So as we know that usually many USGs are done, isn't it? If we go to the tertiary hospitals, then many USGs, one is done during the first trimester, that is known as a dating scan, okay, that is used to predict the expected date of delivery. The first trimester scans are the most accurate in terms of determining the expected date of delivery. But in terms of ultrasonographic scanning in pregnancy, what is most important is the anomaly scan. It is the anomaly scan usually done between 18 and 22 weeks, ideal time is 20 weeks, right. So that is the most essential scan that is to be done, where we check for severe congenital malformations or anomalies in the fetus, okay, and we can also screen for things like Downs, right. So that is done by this anomaly scan. That USG examination is mandatory. In a pregnancy for antenatal checkup, at least one USG examination is mandatory, and that one USG examination should be a anomaly scan done between 18 and 22 weeks, right. So these are the investigations, the blood tests, urine tests and USG examination, right. Next, what is a high risk pregnancy? What constitutes a high risk pregnancy? Okay. So what is a high risk pregnancy? At risk mother is a mother who possesses identifiable maternal or fetal factors which significantly increase the probability of morbidity or mortality before, during or after delivery, okay, compared to a normal pregnancy. So any maternal or fetal defect or disease or deformity that predisposes the mother to potentially have an adverse feto-maternal outcome, where the mother or the baby can be suffering from problems, okay. Those are classified as high risk pregnancies, okay. High risk pregnancy again is a very common MB question, okay. What is a high risk pregnancy? What are the different types of diseases where we classify the pregnancy as high risk pregnancy, and what are the programmatic provisions to take care of high risk pregnancies, okay. So which pregnancies classify as high risk pregnancy? First is if there is what we call bad obstetric history. So what counts as bad obstetric history? For this lady that we saw, we see that there is a history of abortion and stillbirth, isn't it? Both constitute as bad obstetric history, isn't it? So if there is a history of recurrent abortions, stillbirths, preterm labor, congenital malformations, obstructed labor or previous cesarean section, this is all talking about previous pregnancies, okay. Congenital malformation in previous pregnancy, preterm labor in previous pregnancy, obstructed labor or previous cesarean section. So every repeat cesarean section pregnancy, like every pregnancy in a mother who has previously undergone a cesarean section, has to be treated as a high risk pregnancy. Always remember this, okay. So previously if a cesarean section is done, that pregnancy is a high risk pregnancy, okay. Next is age and parity. So as we know, both extremes of age are high risk. So if there is a pregnancy that is occurring in a lady less than 20 years of age, that constitutes a teenage pregnancy, or advanced more than 35 years in age, then that is a elderly preemie, that is also a high risk pregnancy, okay. And if it is grand multipara, that is more than 4, suppose this is the 5th gravidity, okay, that is also constitutes as a high risk. Okay. So age and parity. Next is medical conditions. In medical conditions, most important is severe anemia. As we know, severe anemia is classified as hemoglobin less than 7, isn't it? Hemoglobin less than 7. So severe anemia, we were already discussing. See, all of the things that we are screening for during the antenatal investigations come here. Anemia, hypertension and preeclampsia, we were screening for this. Urine for protein we were doing, isn't it? We also measure BP regularly. Then gestational diabetes mellitus, we were doing OGTT. Then HIV, syphilis, isn't it? And then other endemic diseases that are present. So as we know, thyroid disorders are endemic for the entire country, okay, not sub-Himalayan belt. Thyroid disorders, entire India is endemic to thyroid disorders, okay. So hypothyroidism, tuberculosis, any cardiac illness, you know, cardiac illness not so common now, but previously we used to have a high burden of rheumatic heart diseases, isn't it? That is also a problem, okay. So these, if these are present, they constitute a high risk pregnancy. So bad obstetric history, age and parity, some medical conditions. Next, complications of the current pregnancy. So findings in the current pregnancy, like if there is twins or triplets, that's a high risk pregnancy. Malpresentation, breech transverse lie, high risk pregnancy. Antepartum hemorrhage, RH incompatibility, if the placenta is a low lying placenta or placenta previa, these all constitute as high risk pregnancy. So see, these are things that during the USG scan at 20 weeks, a pregnancy not previously labeled as high risk may be converted to a high risk pregnancy based on the USG scan, isn't it? There we will look for the position of the placenta, where it is lying, isn't it? So these are the current pregnancy complications where the pregnancy will be classified as a high risk pregnancy. Next, some parameters of the mother. If the mother has a very short height, isn't it? Then what happens? There is cephalopelvic disproportion. The baby's head is larger than the width of the pelvis. So there you cannot have a normal delivery. So those are also classified as high risk pregnancies. Okay. So if you are asked what is a high risk pregnancy and what are the conditions in which we will classify a pregnancy as high risk pregnancy, these are the things that you should remember. Is that okay with everyone? What to tell the pregnant mother? That okay, you are a high risk pregnancy, for you I am going to take additional care. Okay, what is the programmatic provision for taking additional care in high risk pregnancy? Which program specifically addresses high risk pregnancies? Pradhan Mantri Surakshit Matritva Abhijan, PMSMA. Okay, what is done under it? 9th of every month. 9th of every month, there will be a obstetrician or gynecologist who will come to the PHC to do antenatal checkups specifically for high risk pregnancies. So routinely the medical officer will take care of the antenatal visits, but for all high risk pregnancies under PMSMA, 9th of every month, there will be at least one checkup by a gynecologist or obstetrician. Okay. Now what we will tell the pregnant woman is what she should be aware of. So every high risk pregnancy can have some fetal and maternal complications. So such that those fetal maternal complications do not end up in serious morbidity or mortality, the pregnant woman needs to take care of some things. So these are the danger signs that are explained to the mother. Every mother of a high risk pregnancy has to be explained these things, that if any of these are occurring, then you must come to the facility and then we will take care of you. You should not stay at home. So what are the things? Fever more than 38.5 degrees Celsius if it's lasting for more than 1 day. So fever that is persisting beyond 1 day, more than 38.5 degrees Celsius, that is a high risk. Then headache or blurring of vision. Why? This is common for preeclampsia, eclampsia. Okay, high BP. So headache and blurring of vision. Next, generalized swelling of the body and puffiness of face. Again, preeclampsia, eclampsia. Okay. Next, palpitations, easy fatigability or breathlessness. Okay, whether she is having any cardiac complications, whether she is going into heart failure. Okay. Next, pain in abdomen. Okay, many a times there can be problems with perfusion. That manifests as pain in abdomen. Okay, then vaginal bleeding or watery discharge, whether there is premature rupture of membranes, whether there is antepartum hemorrhage, whether there is any infection. Okay, and finally reduced fetal movements. If the baby is not moving, that means again there could be cord around the neck, there could be other problems of perfusion. Okay, so these are the high risk signs that needs to be explained to the mother, that if any of these are happening, then you quickly come to the facility and seek care, isn't it? So we have come to the end of the discussion of the first problem card. So the questions were, what is the schedule of antenatal visit? Clear with everyone, right? What is antenatal registration? What to get registered? What is its significance? What are the routine investigations? What are high risk pregnancies? And what needs to be conveyed to the mother in high risk pregnancies? And what are the programmatic provisions to take care of high risk pregnancies? Clear so far? Okay. So we go to the next problem card. So what is this? Anupama, a 27-year-old premigravida, was found to have pallor during her visit to the ANC clinic at 20 weeks. Okay. Her weight was 48 kg, which has not increased in the last 3 months. Now, how will you manage this case? What advices are to be given to Anupama? If the weight has not increased or increased very little, say less than 3 kg, then by the end of pregnancy, what could be the possible dangers? Okay. So as we know, what is the ideal weight gain in pregnancy? Ideally 12 kilograms. Okay. 10 to 12 kilograms, first trimester 1 kilogram and 5 kilograms in the second and third trimester. Okay. 1 kilogram in the first trimester and 5 kilograms each in the second and third trimester. So total around 10 to 12 kgs of weight gain should occur during pregnancy. So here what they are saying, so what are the important points in this? That she is a premigravida, 27-year-old, but she has pallor. She has come for ANC visit at 20 weeks, but despite coming at 20 weeks, so by 20 weeks she should have had at least 4 to 5 kilograms of weight gain, but she has not had that, isn't it? So her weight is 48 kg, which has not increased in the last 3 months. Okay. So let us go ahead and think what we will do. So whenever you are asked about the management of a case, always remember that you should write it under 3 points. First is, what are the investigations? What is the therapeutic interventions? What will you do for intervention? And what will you do for follow-up? Okay. So investigations, treatment and follow-up. These 3 points should be there whenever you are answering management of any case, right? So as you see, so here the picture of anemia and lack of weight gain, it points towards maternal malnutrition, isn't it? And there could be some underlying disease also. She could be having heart disease, she could be having tuberculosis, she could be having something else which is preventing her from gaining weight and also nourishing the baby properly, right? So what are the investigations that we will do? She has pallor, so definitely we will go for hemoglobin estimation, and by hemoglobin we will classify the severity of anemia. So as we know, in pregnancy we classify anemia as mild, moderate, severe. If the hemoglobin is 10 to 10.9, we classify it as mild. From 7 to 9.9 it is moderate, and below 7 it is severe, isn't it? Then you will go for peripheral blood smear to check for whether there is, first of all, to classify the type of anemia. Okay, whether it is, if it's iron deficiency anemia like it is common, you will have microcytic hypochromic. If there is, but there could be other forms of anemia also, so we need to check. So peripheral blood smear for that, and also to check for malaria. Okay, we will also check for malaria. Next, stool examination. As we know, one of the commonest causes of chronic blood loss is helminthic infestation, and in rural India, where it is commonly prevalent that people walk barefoot outside, so helminth infestations are very common. So we will do a stool examination and then a detailed obstetric and medical history to look for other complications, okay, whether she has any other illness, whether she has had any other problem, we need to take in detail, right. So as I was saying, to also rule out things like tuberculosis, HIV, or there are some practices where they deprive the pregnant women of nutritious food, okay, this you should not take this in pregnancy, you should not take that in pregnancy, these practices are there. So whether such practices are hindering the mother from consuming nutritious food, those are all things that we need to evaluate, okay, to find out why the mother is having anemia and not having any weight gain, isn't it? Then management, as we know, so routinely we give 1 tablet of iron folic acid for 180 days, but here that is the prophylactic dose. Here we will have to give the therapeutic dose, isn't it? So whenever we are having mild or moderate anemia in the till before 3rd trimester, we will always go for iron folic acid tablets. We are thinking that compliance is there, we have adequate time. Why not in late trimester? Not in late trimester because then you will no longer have the time, because once you give iron, the body will have to use that iron, assimilate it, produce RBCs, that takes a time, it takes 1 month, okay. So if the woman is coming with moderate anemia at 36 weeks, then you cannot say that I will give oral iron, okay. But first, 2nd trimester, someone comes with pallor, if it is mild or moderate anemia, then what we do is we will first give therapeutic dose of iron folic acid tablets, which is 2 tablets every day. Now as we know, iron usually we advise in empty stomach, but in pregnancy there is a chance of vomiting. So we do not give iron on empty stomach usually in pregnancy, we will ask them to take it after meal only, okay, we will ask them to take it after meal. Then deworming, 2nd trimester definitely, so it could be due to parasitic infestations, so we will do deworming. And thirdly, since she is not having adequate weight gain, we know that during pregnancy from the ICDS, mothers are giving supplementary nutrition, isn't it? So we will see whether she is taking the supplementary nutrition, take home ration from the Anganwadi center, ICDS center. If not, we will map her to that, okay. And follow up, so we will reassess the hemoglobin after 1 month, and we will check whether the hemoglobin is increasing and whether she is having adequate weight gain. If not, we will refer her to a first referral unit where she will be managed by the hierarchist, right. So what is the program that takes care of management of anemia? Name of the program is Anemia Mukt Bharat, isn't it? The name of the program is Anemia Mukt Bharat. So under Anemia Mukt Bharat, we have guidelines for the management of mild, moderate and severe anemia, okay. So for mild and moderate anemia, you see the first line of management is iron folic acid tablets, 2 tabs, isn't it? But if the mother is presenting in advanced trimester, or if we are seeing for mild anemia, if the mother is presenting in late trimester, or if we are thinking that there is no compliance to the iron folic acid, then we can consider IV iron, which is given as ferric carboxymaltose, okay. Ferric carboxymaltose IV is given, okay. For moderate anemia, if we are thinking that if the mother comes in late pregnancy, then we will straight away go for IV iron, okay. There late trimester presentation of moderate anemia, suppose they are coming at 34 weeks, 35 weeks, you do not have the time to give oral iron and increase the hemoglobin, okay. So there you go for IV. So depending on what is the timing at which they are coming, we will decide on whether to give iron folic acid tablets or ferric carboxymaltose IV, okay. If it is severe anemia, every case of severe anemia has to be managed in IPD, okay. Severe anemia will not be managed in the outdoor basis. So severe anemia, you admit them, you treat, you give IV iron, or you give blood, or you give, so the management will depend upon the woman. Most times if the mother is having severe anemia, she will also be in, there is a high chance she will also be in heart failure, okay, because there is, as we know in pregnancy anyway, there is a lot of hemodilution, isn't it? Along with that, if there is severe anemia, you cannot right away give blood, okay, because you can precipitate heart failure even more, okay. So those all have to be managed IPD basis, the team will decide what to do on a case-to-case basis. So it depends on what is the physiological state of the woman, and based on that the management is done. Okay. Options are A, to give ferric carboxymaltose IV, or to give blood transfusion. Okay. But blood transfusion we will avoid unless it is in the advanced trimester. Okay. If the mother comes before 34 weeks, we will always try to give iron and not blood. Okay. So what are the advices that you have to give to this mother? Okay. The first and foremost, this we know that during pregnancy there is an additional requirement of calories and protein. So 350 kilocalorie and 15 to 20 grams of protein per day additionally over and above the routine needs, right? So that has to be given, but the mother will not understand this, right? That is for you to know. So what will you advise? You will advise foods based upon this, that the mother has to increase the frequency and portion of her meals, and in that she has to increase protein rich food, whatever is locally acceptable and based on her diet. So legumes, pulses, egg, milk, whatever suits her, you advise for that, right? Is that a reel or is that your ringtone? If it's a reel, it's a problem. Next, iron rich diet. Okay, so to have iron rich diet you need green leafy vegetables, and you require, so animal food, meat, liver is rich in iron also, animal iron. But if animal foods are not acceptable, then you give green leafy vegetables. But one problem with green leafy vegetables is that they also contain phytates, and phytates inhibit the absorption of iron. So there you have to phytates will be there, they will form complexes with iron and it prevents iron absorption. Okay. So there you have to ask the mother to also take vitamin C, which is she will take your routine lemon, that has to be added to your meals during taking green leafy vegetables, because vitamin C will keep iron in the +2 state and ensure that it is absorbed. Okay. So you have to advise regarding iron rich food, regarding increasing calorie and protein, and you have to advise about consuming vitamin C rich foods along with those in order to aid in the absorption. Most importantly, you also have to ask the mother not to take tea or coffee after meals, because tannins are also inhibiting the absorption of iron. Also, you are also prescribing her calcium tablets. So if she is taking the calcium and iron tablet together, both are absorbed in bivalent state, Ca2 plus, Fe2 plus. So they will compete with each other. So you have to tell the mother that do not take the calcium when you are taking the iron, you take it in some other time of the day. Okay. So these are advices that need to be given to the mother so that you are effectively able to increase the iron. Otherwise all will go out in the stool only, it will not be absorbed. Okay. This is a risk that we cannot take in late trimester. That is why in late trimester we will go for IV. Okay. What else? So you need to advise her rest. Okay. You need to advise her adequate rest, and preferably in advanced trimesters, preferably daytime rest in left lateral position, so that there is adequate perfusion during resting, right? And also counsel that if you are taking iron folic acid tablets, you will have black stools. Otherwise, looking at the black stools, she will stop taking your IFA. She will think that she is bleeding. She will think that she is having some problem. So she will stop taking. So you have to counsel that you will take this medication, as a result of this medication you will have black stool, you can have constipation, and also give them a remedy of constipation, that what she will do to deal with it. Okay, so that she does not stop taking your medication, because she is not going to come to you every 1 week. Okay, and also educate her on danger signs, because again it will be a high risk pregnancy. Okay, so educate on the danger signs. All of those danger signs we discussed already in the previous. So what are the possible dangers of poor weight gain? Like the mother, as we discussed, that the mother should ideally have 12 kilograms of weight gain. First 1 kg in the first trimester and 5 kg each in the second and the third trimester. So what if this weight gain is not happening? What are the dangers? So there are some dangers to the mother and some dangers to the baby. So first of all, what are the fetal and neonatal dangers? So once you know, intrauterine growth restriction. So the baby, mother is having 12 kg weight gain, but out of that 3 kilograms is the baby itself. and another 1.5 kilograms is the placenta, the uterus and all of that, 2 kilograms, right. So if she is not having at least 6, 7, 8 kilograms of weight gain, that means there will be intrauterine growth restriction. That is a problem, and that will have all of its consequences, low birth weight baby, it being susceptible to all of those infections and all of that. We'll come to the discussion of low birth weight in the next problem card. Next, low birth weight, as I was already saying. So IUGR, its natural consequence is low birth weight. And thirdly, so both of these combined increased risk of perinatal mortality. Perinatal mortality means stillbirth or death in the neonatal period, isn't it? Death in the early neonatal period, right. Next, what are the maternal dangers? So maternal dangers, preterm labor, okay, preterm labor. Next, maternal exhaustion and infections during delivery. She does not have the energy only, because labor is one of the most tedious and painful processes that a woman has to go through. So she will not have the energy and the ability to go through labor. So obstructed labor will be there, or you have to go for cesarean section, right. Next, she will not have the maternal reserves. 12 kgs weight gain is to have the maternal reserves to be able to breastfeed the child after the child is born. So the mother has to exclusively breastfeed for 6 months after the child is born. So all of the baby's nutrition, the baby will grow in 6 months, all of that will come from the mother. So if the weight gain is not happening, she will not have the maternal reserves necessary for initiation and maintenance of breastfeeding, right. So there will not be successful initiation and maintenance of breastfeeding. The mother is also prone to various infections, okay, because the immunity is also dependent on proteins and energy at the end of the day. All of the immunoglobulins are proteins, isn't it? So these are the various consequences if the mother is not having adequate weight gain during pregnancy that you need to be aware of, okay. So going back to the problem card, there were these 4 questions. How will you manage? So you have to investigate, you have to treat, and you have to advise for follow-up. Then what are the advices to be given regarding diet, regarding rest, regarding the consequences of IFA, and regarding danger signs, right. Next, if the weight has not increased, what are the possible feto-maternal consequences, okay, consequences to the baby and consequences to the mother, right. So next we move on to the problem card 3. Is Tara, a 20-year-old woman, delivered a 2.5 kg baby boy at home, which was conducted by an untrained dai of the village. The baby was normal at birth, but 3 days later he stopped sucking, and then within the next 3 days he developed trismus, violent muscle spasm, and ultimately died on 8th day, okay. Verbal autopsy of the death revealed that the mother did not receive any antenatal care during pregnancy, okay. So what is the most probable cause of child death? What were the reasons which contributed to the death of the child? How could this death have been averted, okay. So what are the important points in this? First and foremost, 2.5 kg, it is not low birth weight. Low birth weight is less than 2.5 kg, okay. So it is just that at the border of low birth weight, okay. Next, the boy was delivered at home. We know that now we advise for institutional deliveries, but this delivery occurred at home. It was conducted by untrained dai, okay. Then at 3 days he stopped suckling, okay. Next 3 days he developed trismus and violent muscle spasm, and finally he died on 8th day. Verbal autopsy says the mother did not receive any antenatal care. So why was verbal autopsy done? What is verbal autopsy? Anyone is knowing? Verbal autopsy is a practice in which, by interviewing the relatives, we try to ascertain the cause of death, okay. For all maternal deaths and for all child deaths, there is a mandate to conduct maternal death reviews and child death reviews, okay. For all maternal and child health, maternal and child death reviews have to be conducted, okay. Since this for the, if it is in the hospital, then a in-hospital review is conducted, okay. But since this child died at home, then a death review will have to be conducted there also. Okay, it is a mandate under the national programs that every maternal and child death has to be reviewed. So, how to review a child death that has occurred in the community? The option is to do a verbal autopsy, where you cannot do an autopsy there, but you are trying to find out the circumstances and the things that were happening on the road to the death. Okay, so what tried to happen? A sequence of events, we try to reconstruct that by interviewing various community people and relatives. Okay, that is known as verbal autopsy. So going ahead, what is the most probable cause of this child death? It is, as we know, it is neonatal tetanus, isn't it? The child died on the 8th day. As we know, neonatal tetanus known as the 8th day disease, isn't it? So initially when the baby is not suckling, that is due to gradual development of the spasm of the masseter muscle, or as we know, lockjaw or trismus, isn't it? And then gradually as the disease progresses, the baby has general violent muscle spasms, and finally the child death occurs on the 8th day. So this is the characteristic presentation of, neonatal tetanus. Okay. So what are the reasons contributing to the death of the newborn? First and foremost, it is the lack of antenatal care. Why? Because during antenatal care, the mother should have got the TD vaccines. If she got the TD vaccines, then the antibodies against tetanus would be transplacentally transferred onto the baby. The baby would have passive immunity, passive artificially induced immunity against tetanus due to the mother's antibodies coming into the baby. We are artificially inducing it by vaccinating the mother, okay, and the antibodies will come to the baby by crossing the placenta, okay. But since the mother was did not get antenatal care, mother did not have the antibodies, did not come to the baby was not protected against tetanus. So first is lack of antenatal care. Another thing that is there in the lack of antenatal care, that is, if antenatal care was there, then she would definitely, one of the components of antenatal care is birth preparedness and complication readiness, known as BPCR, birth preparedness and complication readiness. So in 3rd trimester antenatal care visit, birth preparedness and complication readiness is taken care of. So the mother would be mapped to a facility where she would be confined for her delivery. So the home institutional delivery also would not have occurred if the mother was having antenatal checkups. Okay, so that is why antenatal checkups not having is a main problem here, directly for tetanus and also for having the home delivery. Okay, next, unsafe intrapartum practices, that is unsafe delivery. Why? Because now we know the national mandate is that every delivery must be attended by a skilled birth attendant. They must be attended by a skilled birth attendant. Here it was conducted by a untrained DAI, isn't it? So the 5 C's of delivery were not taken care of, okay, and that can also, contribute to the death. Okay, so tetanal spores typically enter the newborn's body through the umbilical stump, isn't it? And we have practices of putting cow dung and ash to the umbilical stump, or if the baby is having the delivery at home, then the scissors are not sterilized. We autoclave in the facilities, all of those equipments are autoclaved or sterilized by dipping them in disinfectant solutions, okay, but those things are not done. Or if it is tied with some unsafe tie, okay, some thread or something which is not safe, all of that can lead to neonatal tetanus. Okay, so one cause is the lack of antenatal care, second is the lack of institutional delivery, which is delivery conducted by untrained people, and third is delayed care seeking. We know that now we have the mandate of home based newborn care. Okay, under home based newborn care, the ASHA worker has to go and visit the home of the child on various days. So this was a home delivery. So the ASHA worker should have gone on day 1, 3, 7, 14, 21, 28, 42. Okay, and if for institutional delivery, the baby stays in the institution for the first 2 days in normal delivery. So it begins from 3rd day, 3, 7, 14, 21, 28, 42. Okay. So at 1, 3, 7 in the first week and at 7-day intervals till 1 month and then at 42 days. Those are the home-based newborn care visits. So if the ASHA worker was going and doing those visits, if the pregnancy was a registered pregnancy, if the delivery occurred at, even if the pregnancy did not have any antenatal checkup, only the delivery occurred at the hospital, then during the delivery only she would be given the MCP card. Okay, and she would be mapped with the public healthcare system. So the ASHA worker would go and conduct the home-based newborn care visits. So then we would be able to detect the baby when it was having the initial symptoms of showing lethargy, not suckling properly, and then we would be able to treat neonatal tetanus in an effective way. But since the pregnancy was not with the public healthcare system, even that opportunity got missed here, isn't it? So next is, what are the ways to have averted this death? First and foremost is antenatal checkups, isn't it? Getting the pregnancy registered and getting the maternal immunization done. Next, safe delivery practices. So institutional delivery should have been done, attended by a skilled birth attendant. Along with that, adherence to the 5 C's. So what are the 5 C's? Clean hands, clean delivery service, clean cord cut, clean cord tie, and clean cord stump. Okay. So these are the 5 C's of safe delivery. Okay. Even if it was done at the home, at times, you know, during emergencies, some deliveries might have to be conducted at home. So even if it is conducted at home, there are disposable delivery kits that are available and under the national program provided with the ANM and the ASHA. So with the disposable delivery kits, these 5 C's can be maintained and the delivery can be conducted at home. But even that here could not be done. Okay. So antenatal care should have been given and it should have been an institutional delivery. If institutional delivery was not possible, maybe distance, maybe transport, maybe emergency, maybe not wanting to come to the institution, then at least a disposable delivery kit and a trained birth attendant should have been there for the delivery. And next, as I was saying, home-based newborn care. So the ASHA worker, so here since the death occurred on the 8th day only, so before this on the 1 and it was a home delivery. So on 1st, 3rd and 7th day ideally the ASHA worker should have gone and visited. So then she would find out that this baby is having certain problems and necessary measures would have been taken, okay, to prevent the death. Like ASHA worker would refer and then the baby would be treated, but that was avoided here because of lack of these things. Okay. So we have discussed again this problem card. We had 3 questions. What is the most probable cause of death? We have discussed that. What were the reasons which contributed to the death of this child? We have discussed. And how could this death have been averted? We have discussed it. Okay. Any questions so far? Okay. So we will move on to the last problem card. So this is another case of problem with the child. Bella. Bella is aged 18 years. She delivered normally her second daughter in a PHC on 18th July. Okay. She delivered her first child on 13th June last year. The birth weight of the child noted by the ANM 10 minutes after birth was 2200 grams. The child was given to the mother after 40 minutes and they were discharged on 19th of July. Okay. So we have 5 questions here. Comment on the birth weight of the child and state the probable causes of such a birth weight of the baby. Okay. Next, chalk out the schedule of postnatal visits. We have already discussed that. We will see again. Where the mother and the child discharged after an ideal time after delivery. Justify. Okay. Mention the complications that can arise from this condition of the newborn and what advice the ASHA should give to the mother regarding this newborn. Okay. These are the questions that you can be asked from this problem card. So there were 3 problem cards actually which were similar to this problem cards. I have compiled the questions of all of those 3 problem cards into this one, okay, for paucity of time. So again, so what are the important points? First is Bella is aged 18 years. So this is a teenage pregnancy, isn't it? This is a teenage pregnancy. She was admitted on 18th and discharged on 19th. Okay. So her period of staying in the hospital was only 1.5 days at max, isn't it? Next, she delivered her first child on 13th June last year. That means, what is the conclusion out of this? Spacing is not there. The adequate spacing is not there. The child, last child was in June. This child is in July. That means only 1 year gap between consecutive childbirths. Okay, that means only around 3.5 month gaps between consecutive pregnancies, isn't it? Next, birth is 2200 grams. That means this is a low birth weight child, isn't it? This is a low birth weight child. And child is given to the mother after 40 minutes. Now this is what kind of delivery? What kind of delivery? Normally delivered. So if it's a normal delivered child, what should be the early initiation of breastfeeding? Within 30 minutes. Within 30 minutes for normal delivery. Okay. So here the exclusive breastfeeding is also beginning at a later. Though early initiation is within 1 hour, but it is advised that for normal deliveries it should begin within 30 minutes. Okay. So let us go ahead and discuss. So recorded birth weight of the child is 2200 grams. That recognizes that this is a low birth weight child. So what is the definition of low birth weight? Birth weight of the child less than 2500 grams irrespective of gestational age. Okay, do not forget to mention that later part. Irrespective of gestational age. Birth weight of the child less than 2500 grams irrespective of the gestational age. So if the baby is at term and still less than 2.5 kilograms, then the baby is a small for gestational age baby, SGA, small for gestational age baby. If the baby is born before term and it has a weight of less than 2.5 kilograms, that is also low birth weight, but that is preterm. That is preterm. So low birth weight babies includes both preterm and small for gestational age. So it is low birth weight is defined as birth weight of the baby less than 2.5 kilograms irrespective of the gestational age. Is that clear? Do not forget the irrespective of the gestational age part. Okay. Otherwise there is a confusion. If you do not remember this part, the examiner will tell you, now imagine a baby was born at 30 weeks and it has a weight of 2.4 kilograms. Now will you classify this as low birth weight? And then you start wondering that okay, 30 weeks. So then if the pregnancy continued for 38 weeks, then the baby would be 2.7 kg maybe. Then should this baby be low birth weight? No. We'll just look at what was the weight at birth irrespective of gestational age. If it is less than 2.5, it is low birth weight. Because if it is less than 2.5 and the baby is out, that means the baby is out. Now it will have to deal with the outside world. Now if it is having that less weight, it is not capable to deal with the external world. That is what we are concerned about here. Okay. So what are the probable causes? In this case, as we know, it is teenage pregnancy. Okay. The teenage pregnancy, in the teenage mother is still growing herself. So she has, during the late adolescence, there will be widening of pelvis, you know, accumulation of fat in specific areas of the body. So during teenage years, the mother is developing her body herself. Her own body has got nutritional demands. So during that, if there is another parasite which is developing within her and that is consuming nutrients, how will her own body develop? Okay. So during teenage pregnancies, there is always a competition for nutrients between the fetus and the maternal body, and that leads to complications like low birth weight. Next, here no spacing, isn't it? The advice for adequate spacing is that there should be at least 2 years, 24 months gap between consecutive pregnancies. That means there should be at least 3 years of gap between consecutive childbirths. Is that clear? there should be 3 years gap between consecutive childbirths. There should be 2 years gap between consecutive pregnancies. That is because end of one pregnancy itself is 9 months long. Okay, so you have to have that difference. 3 years, if you are estimating it from the age of children, then you have to look for 3 years. If you are estimating it from the pregnancies, then it is at least 2 years. Always be aware of this thing. Okay, so here the gap is 1 year. That means there is only 3.5 months gap between the consecutive pregnancies. That means while the mother was breastfeeding the previous child, this child she has become pregnant. So what will she do? Will she nourish? She is teenage. She will have to nourish her body. She will have to nourish the child she already has, and she will also have to nourish the fetus which is growing inside. So high chance of having a low birth weight child and maternal complications here, right? So going ahead, what is the schedule of postnatal visits? So as we know, for home based newborn care, the ASHA worker has to go and do home visits. Okay, during home visits she has to, so if the delivery, so there are 3 kinds of delivery. First and foremost is the home delivery, in which delivery is at home only. So ASHA worker has to go and visit from 1 day, 3rd day, 7th, 14th, 21, 28, 42. If the delivery is a institutional normal delivery, then the mother will stay for 2 entire days, that is for 48 hours. Then she will be discharged. So on the 3rd day, she will be discharged. So the visits will begin from the 3rd day. 3, 7, 14, 21, 28, 42. 1 visit less than home delivery. If it is institutional caesarean section, then the period of confinement will be longer. It will be up to 5 days. So then the visits will begin from the 7th day. Then 7, 14, 21, 28, 42. Okay. So these will be the home based newborn care visits depending on the kind of delivery that is occurring. Is that okay? So what will the ASHA worker look for? There are 2 things she will look for. A, she will look for the newborn and the mother she will examine. What will she do? She will provide essential newborn care. She will examine the newborn. She will look for early recognition of danger signs, stabilization and referral. This is her work for examining and taking care of the mother and baby. Other than this, she has to counsel the mother regarding some things. So what will she counsel on? She has to counsel on breastfeeding. She has to counsel on providing problems of newborns or hypothermia. Okay. So she has to counsel on providing adequate warmth. This is a low birth weight child. What will be advised? Kangaroo mother care, isn't it? Kangaroo mother care. What is the difference between skin to skin contact and kangaroo mother care? Kangaroo mother care is provided for a longer duration. Okay, the session should be 60 minutes to 90 minutes long, 1 to 1.5 hours long. Okay, and the kangaroo mother care has got some specific objectives which are not there with skin to skin care. Okay, so kangaroo mother care is specifically applicable for low birth weight children, where the mother usually has to keep the baby between her breasts. Okay, and the baby will be kept for long duration, 60 to 90 minutes at a stretch. Kangaroo mother care can also be provided by the father. Okay, it is not like it has to be only the mother who provides them, right? So counseling the mother on breastfeeding, on warmth, on care of the baby, immunization. As we know, there will be some, so home delivery agar hota hai to birth immunizations, then immunizations at 6 weeks. Okay, so counseling on immunization, we have the greatest misses from the public healthcare system between birth and 6 weeks. Birth ka immunization at the facility ho jata hai. Uske baad once you discharge them, they do not come back for the immunization at 6 weeks. So counseling for immunization. Okay. Postpartum care and use of family planning. Okay. At 6 weeks, the ASHA worker will try and convince the mother to start thinking about some family planning method which she will adopt. Okay. Now when is the home based, how do we, so Asha worker will be doing so many things, she gets an incentive of 250 rupees for this. Now when will she get that 250 rupees? She will get it if some things are ensured, that is the birth weight is recorded in the MCP card. Okay. Next, ensuring that the newborn is immunized with the birth dose vaccinations. Okay. Next, what is wrong? Any problem? Okay. Next, ensuring birth registration, that is the birth has been registered, a birth certificate has been given. And next, both the mother and newborn are safe until 42nd day. So as we know, the first immunization is at 6 weeks. So all of those things have to be, maternal mortality is counted till 6 weeks. So factoring in all of these things, home based newborn care, the last visit is at 6 weeks, is at 42nd day. Okay. So if these are completed, the Asha worker gets the incentive that she is supposed to get, right? Next, ideal time of discharge. So no, isn't it? So the recommendation is that the confinement following normal delivery is at least for 2 whole days, that is for 48 hours. So if the discharge was earlier, that means safe confinement has not happened. What are the problems that can happen here? You can have delayed PPH, postpartum hemorrhage. Okay, with the newborn who is a low birth weight newborn, you can have problems of hypothermia. You can have delayed initiation of breastfeeding. There can be faltering of breastfeeding. So for that reason, at least 2 days confinement is necessary. Okay. So what are the complications that can arise from this situation? So neonatal complications, as we know, neonatal hypothermia, because the baby is low birth weight, the baby does not have the brown fat reserves that are necessary to prevent hypothermia. Okay. Next, you have neonatal hypoglycemia, again does not have the energy reserves. Okay. And teenage mother, she might not be able to provide the sufficient nutritional requirements of the baby. So risk of neonatal hypoglycemia is there. Neonatal sepsis, if there is no energy reserves and a low birth weight child, risk of infections and feeding difficulties. Low birth weight babies, they do not have the suck, swallow, coordination. Okay, the breathing and the sucking and swallowing coordination, that coordination does not match. So it is difficult to feed those babies. Okay, and they also have weak jaw muscles. So they cannot suckle effectively if they are preterm. Okay. So these are the possible complications that can arise. Okay. Last thing is, what advice has to be given by the Asha worker to the mother. So what advice again? So advice regarding kangaroo mother care and exclusive breastfeeding. Next, advice regarding delayed bathing. So the baby has to be sponged and mittens and socks have to be worn so that the baby does not go into hypothermia. Next, infection prevention and danger signs. So we have already discussed what are the maternal danger signs. We also need to know what are the neonatal danger signs. So what are the danger signs in a child that need to be counseled to the mother so that she is able to recognize the early danger signs and take the necessary measures. So what are they? Refusal to feed, lethargy, cold extremities, fast breathing and yellowing of skin. So pneumonia, jaundice, cold extremities, hypothermia and lethargy or refusal to feed. Those are all predisposers of hypoglycemia and any disease, any kind of neonatal sepsis, it manifests as lethargy. Okay. So that is the end part of the problem cards. Okay. So this problem card we had 5 questions. We have discussed all of those 5. Okay. In this PPT I have also kept in brief the programs with their logos so that you are able to read on their own. Okay. So when I circulate, these have already been covered. Just be assured that you are recognizing every logo of the program and you are oriented to that. Okay. So there are slides on Janani Shurakha Yojana, on Janani Shishu Surakha,   Shurakha  Karyakram, on Pradhan Mantri Matru Vandana Yojana, on Pradhan Mantri Matru Vandana Yojana, on Janani Shishu Surakha Karyakram, on Pradhan Mantri Matru Vandana Yojana, on Pradhan Mantri Matru Vandana Yojana, on Janani Shishu Surakha Karyakram, on Pradhan Mantri Matru Vandana Yojana, on Janani Shishu Surakha Karyakram, on Pradhan Mantri Matru Vandana Yojana, on Janani Shishu Surakha Karyakram, on Pradhan Mantri Matru Vandana Yojana, on Janani Shishu Surakha Karyakram, on Pradhan Mantri Matru Vandana Yojana, on Janani Shishu Surakha Karyakram, on Pradhan Mantri Matru Vandana Yojana, on Janani Shishu Surakha Karyakram, on Pradhan Mantri Matru Vandana Yojana, on Janani Shishu Surakha Karyakram, on Pradhan Mantri Matru Vandana Yojana Pradhan Mantri Surakshit Matritva Aswasan, Lakshya, which is the Labor Room Quality Control Initiative, and Surakshit Matritva Aswasan, Suman. Okay, that is the Citizens Charter which ensures respectful maternity care. So, and that all pregnant women are aware of what services they need to get. Okay, so for your exams, you need to be oriented that these programs are existing as part of the RMNCHA umbrella, right?